All right, y'all. So this week's research spotlight is postural control during sit to stand and gait in stroke patients. So it's a little bit of an older article. I think it's from 2003. We had to read it for one of our movement analysis sessions this past week. But I thought it brought up a few good points, and it kind of relates back to some of the other articles that we've talked about, including the one that talked about sit to stand, which I believe was last week's. And basically what they found is that in patients post-stroke, a major determinant of their functional ability following stroke was their ability to rise quickly from sit to stand. I believe it was under 4.5 seconds, and then their amount of weight distribution between their paretic and their non-paretic leg. And if the distribution is less than 30%, they demonstrated improved functional outcomes, mostly demonstrated by improvements in gait. So one of the big takeaways that I took from this was that, one of our mentors kind of talked about with us, was that the distribution between the amount of weight that they put in their involved and their uninvolved limb is super, super important. And it's not necessarily based on, how much their center of mass kind of sways mediolaterally during sit to stand. It's all based on how much weight they're putting through that involved lower extremity. So when you're focusing on intervention, really focusing on not necessarily keeping the hips in line, but focusing on driving through that involved lower extremity and really trying to push through that into the ground, squishing the bug. If you have the availability of the little force plates that have the little lights on them, I can't remember what they're called. I know they have them in the clinic at Ithaca on campus. Then you can use those, and you can use other techniques to help facilitate increased weight through one lower extremity, particularly the involved lower extremity, because the closer you can get the distribution of weight towards a 50-50 split, which is pretty much seen in healthy controls, it's like 49 to 50% per leg. The more effective their gait pattern is going to be, and the more effective their sit to stand is going to be. So I thought that was an interesting takeaway. I think sometimes we as therapists want to focus on, making sure we're shifting their hips towards that side, or shifting their center of mass, when we really should just be focusing on driving through that involved leg for our patients post-stroke. So that's this week's Research Spotlight, short and sweet, and hopefully you find this article helpful and it'll help you with your practice. Thanks for watching.